Welcome, everybody. This is our International Forum on Quality and Safety in Healthcare webinar series on impact and focus. As I said, please do introduce yourselves in the chat. Say hello, say who you are and where you're from today. As many people as we can collect in the chat, that will be wonderful. My name's Selina Stephen, and I'm the Director for Global Forums at the Institute for Healthcare Improvement. Now, IHI and the British Medical Journal work in partnership to bring you the International Forum on Quality and Safety in Healthcare. And this webinar series showcases our top scoring posters from the International Forum in Oslo in 2026. Now, some of you may have been in Oslo and you will know we had a fantastic forum. It was a really great 3 days, and we were incredibly fortunate to have some fantastic posters. And today we're delighted to feature our technology stream. So the format of today, we'll have a presentation from Tom, who will tell us all about the work behind his poster. And we will follow this by a question and answer discussion session. So as you are listening to Tom's presentation, please do start to have a think about any questions you might have for him. And either if you're happy to wait until the end, then raise your hand and we can have a conversation. Or if you would prefer to put your question in the chat, then that's absolutely fine. And I can direct your questions for you to Tom after he's finished his presentation. A quick reminder that this session is recorded. So we are going to allow the people who have registered but not able to actually make it live to the webinar to watch as well. So as I say, this is recorded. So without further ado, let's get on with it. I have great pleasure in introducing Tom Imberechts here. So Tom is a medical policy information officer of the medical department at the Hospital of St. Blasius in Belgium. I've been practicing saying that. Thank you, Tom, for the coaching.
Very well.
Thank you. Tom is particularly interested in integrating technology into daily medical practice. And under Tom's leadership, his hospital was the first to implement telemonitoring into acute care, especially with an interest in post-surgical follow-up. So Tom is a trailblazer for us here. And those of you who saw his poster in Oslo will know that it's a remarkable piece of work. So get your pens out, take some notes, and I'm going to hand over to Tom to tell us about his work and tell us his story. So Tom, thank you very much.
It's a pleasure. It's not only my work, of course, it's work of an whole team. So the main author was not able to join, but I'll follow in her footsteps. I'll share my screen.
Yeah, go for that.
So that's visible for everybody, I guess.
Yes, you're on.
Yeah, and now I'm on presentation mode.
Very good. Perfect.
So, good morning, afternoon from wherever you are. I'm Tom from AZ in Blasius, a mid-sized hospital in Belgium. And today I'll take you through TOTEM, which stands for Transmural Care with Telemonitoring. And it's a project that enables patients to safely recover at home after surgery while maintaining care quality and patient safety. I'll take you through the process from design to discharge with some challenges to which TOTEM provides answers to a certain degree. So RPM, remote patient monitoring, lots of definitions, but it involves always collecting medical data from patients outside traditional healthcare settings using digital technologies. Think vital signs, questionnaires, observations. And those data are transmitted electronically to healthcare providers for assessment. But important here is that we are changing the location of the patient. But with this move, we also change the location of the risks. So we need to address those risks to keep our patients safe, which means new responsibilities or responsibilities assigned to new roles in our healthcare setting. The major challenge is not technology. The major challenge is the reorganization of our healthcare. This is not me speaking, this is literature speaking. RPM delivers significant benefits. Improved patient safety, less major complications, or if there are complications, we detect them sooner. The adherence of patients is better, which has a positive effect on the clinical outcomes, quality of life outcomes, and also cost-related outcomes. Big but, there are methodological differences regarding research. It's not so easy to compare results. Academics listening will certainly agree, I guess. But next to this, for the practitioners, there are also differences in implementation. Implementation is quite often incomplete or misaligned with the existing care processes, or mainly too focused on chronic conditions. And as Selena said, we did it in an acute setting. It's post-operative, so it's something completely different when compared to chronic conditions. What did we learn? RPM works, but it only works if it's well designed and if it's integrated in current care pathways. How did we do it? We used the telemedicine program design canvas. It avoided quite some pitfalls. It's a tool that was designed by Oxford University. It's free available, so kudos to them. But this tool helps us to map out all the critical aspects from patients to providers to technology costs. And which is key is that it shows that RPM can be systematically implemented. The two most important parts of this canvas are top left, which problem do you need to solve? Problem for a patient, problem for a healthcare institution, problem for a health system. And the bottom right, which is the desired outcomes. What will success look like? Where will you focus yourself on? Next to that, of course, the canvas provides us with all the questions we need to answer when designing the care path, but we also use a methodology. Most start from left to right. They start from care path and they will add telemonitoring to it, but then telemonitoring is an add-on, it's not integrated. So we change it. Quite straightforward, we start from right to left. We always start with the goal, we always start with the problem we want to solve. In our case, we wanted good clinical remote assessment of specific post-surgical patients by detecting as rapid as possible the complications. But it's always, you always start from an existing situation. It's not a blank slate. You're already doing a clinical assessment of post-surgical patients. You're using vital signs and observations. You have different roles that will contribute. There are workflows in place. You have a kind of education for all those different roles. But when you use telemonitoring, when you use RPM, you need to change those. Which vital signs and observations do we need and how are we going to gather them? So you need technology, which means you get other tasks which needs to be allocated to different roles. There are flowcharts that needs to be changed, and your education also will change from a more clinical view to also a technical and a process-based approach. If you do this right, you get to a new care pathway, which is totem post-surgery in our case, where you have an integrated care path with telemonitoring. What is important here is the overhead. It looks like that every healthcare provider in Belgium is working the same, but it's not true. There are organizational differences, and you need to be aware of them. Different healthcare providers have different legal boundaries, other financial boundaries. There are other financial incentives. So it's always, you can start to try to get one care path for one pathology, but it's not always feasible. This leads to a quite colorful new care path, integrating the RPM. So this is a real-world example for bariatric surgery. It's a care pathway starting from pre-operative inclusion to post-operative monitoring. So it's not only post-operative that we're working. We need to include the patient. We need to provide them from prescriptions and information quite a long time before they are in the operating room. RPM activation, of course, is post-operatively, and we measure patients between 5 or 10 days after surgery. But as already stated, we started with a problem, and it was a problem from a surgeon who approached me and said, I am doing everything I can to get the patient home as soon as possible. I am integrating the ERAS protocol, early recovery after surgery, less fluids, other sedatives, is using most of the time robot surgery, which leads to a length of stay after, in his case, colorectal surgery for 1 or 2 days. So he told me early discharge really is possible, but the complications stay the same. But when they were in the hospital, we saw them happening in the hospital. When we discharge the patient, there is a safety issue for our patient. So what are the considerations if you want to go to an early discharge from the patient? There are a lot of opportunities. Capacity management. We will have more beds available for our patients, or we can diminish our beds. Acquired hospital infections, of course, statistically, it will be less. Comfort at home. Everybody likes to be in their own bed, not in a hospital bed, which is not so nice. And the financial benefit, but mainly from a government perspective, not for the hospital. Government and healthcare, the financial benefit is with them. But what are the weaknesses? It's safety. If you want to tackle the complications, how are we going to detect them early, as soon as possible? How are we going to take correct action? Because it's not only detecting them, it's doing something with them. It's keeping the patient safe. We needed a control mechanism, and we didn't have it. So we focused on just one main goal, and that was safe recovery at home, not less the diminishing length of stay, not cope with the workforce shortages. Let's first tackle the problem of safe recovery at home. This is our use case. It's a government-funded project, data innovation, it was called. We had 6 hospitals in Belgium, 2 home care providers, an ICT partner, and then a patient monitoring center, a care center, actually, Z+, which was our single point of contact for our patients. So they didn't need to search for who they needed to contact. They can always contact our care center, and they were always in connection with us in the hospital. We had 9 types of surgical interventions chosen by the doctors, by the surgeons. But we thought we would end up with 9 pathways, but we ended up with 14 pathways because the overhead, different organizational structure, different people available, different financial incentives, different legal boundaries. So that was quite unexpected. Governance was a challenge because you have different autonomous organizations, all with different ideas and different goals. So we needed project management methodology. We started with a steering committee with all the stakeholders at the table. We had several working groups, technological working groups, clinical working groups, pathology working groups. Of course, shared dashboards, but communication is key. Not only formal communication, you need a lot of informal communication as well. We had regular feedback loops, of course, but what was most important was the shared goal setting. We needed to keep the eye on the prize, the continuous focus on the goal, because when your scopes start creeping, you get into trouble. So everybody needed to be aligned, which was quite difficult at times. Data collection, how did we do it? We had three types of data. The vital signs, of course, which were measured by measuring devices. We had questionnaires, which we changed according to the pathology. Urology and colorectal surgery is something completely different, so you need to ask different questions to the patient. Observations of the home nurse, of course, as well. But this is the easy part, because then you can have an algorithm that starts beeping. But what are you going to do when there is a problem? That's the main focus. How are we going to keep our patients safe? So we designed very strict escalation protocols where our care central would first of all contact the patient through telephone, but most of the time to video call to clinically assess the patient one more time. It's very valuable for your patient as well, because they have a human voice, because they have a human touch. And when there was something wrong, when the care center knew there was something wrong, they contacted us, and our surgeon appointed, dedicated to the task, would contact the patient and would get a treatment plan working. It doesn't need to be that it comes to the hospital. Sometimes we can just start some antibiotics while they were at home. It's all possible, but you need the surgeon to contact the patient. We use an app, of course, like everybody, I guess. It was quite simple. We had a clinical dashboard with a very fast overview to see where the problem was. Our surgeons all started with defining the complications for their surgeries, and we started from there so we could see what was the problem, and we were integrated in our electronic health record. So they didn't need to search for data. Results, which is quite important. First of all, we did the expectation measurements. Those were our own questions, mainly focused about safety. Do you feel safe at home when you're monitored by us? And they were very, very high, the results, more than 95%, and they would recommend it at home. It's in Dutch, I know, I couldn't translate it, but patient-reported outcome measures, we used two questionnaires, validated questionnaires, EQ5D and SF36. And we didn't get any results we didn't expect. So they were all pointing us in the direction that it was good what we were doing. It was safe. Another important question was about the providers. How did they do? Because our patients needed to use them. We didn't actually. It's the app, it's monitoring devices. They were very happy about the human touch for our care central. They greatly appreciated it. The app and the monitoring devices there were always technical issues, especially when they needed to have the automatic connection between the device and the app. So actually we stopped and we went to manual. They need to just put in their values, and that worked much better. So to finish, we saw a reduced length of stay with 25 to 50%, which is a lot. It was not our main focus, but it's feasible. Colorectal surgery, we had a mean of 6 days in the hospital. and we diminished it to 3 days. Bariatric surgery, we went from 3 days to 1 day. So that's a lot. But the reduced costs are not for us, they're for the insurer. So there's something wrong in Belgium, I guess. Uh, Early discharge with RPM seems possible, no, is possible. There were no false positives, there were no false negatives. So when our algorithm started beeping, it was right every time. The methodological approach was very, very important. So if you want to integrate RPM in your care pathway, just use a standardized design. Data collection for primary use was very feasible, was not that hard to do. So we integrated it in the electronic health record in 6 hospitals. And very importantly, our patients and our healthcare providers were very, very positive about it. So it really helped them do their job as a healthcare provider, and patients felt safe at home. What was not something we should work about, the sample size was quite small. We had about 200 patients, 189. We didn't have a comparator group because we were mainly focused at implementing something that works. That's the next step. We need to evaluate if people are in the hospital, does something change? So if somebody wants to join, you can contact me. And then the health technology assessment and the health economic assessment, we had a very big problem due to data collection for secondary use. Different parts of data to get them together to have an overview to health economics, that was not possible, so we needed to stop there. So that's it. Those are Philip is my companion, and myself. If there are some questions, you can always get in contact with us.
Tom, thank you so much. That was fascinating, and you took us on a lovely journey. It sounds like a fantastic piece of work, and the most lovely thing for me to hear, which is, I guess, is the same for you, is that your patients felt so safe.
Yeah, yeah,
That's absolutely wonderful.
yeah.
Um, I think our audience may take a little bit of time to get warmed up with any questions. So I've got one for you. But before I ask it, I'd like to remind everybody who's listening today, Tom is here. We're incredibly lucky to have him here, talking to us about this amazing piece of work. So if you have any questions for him or any comments, please do pop them in the chat, and I can translate them and read them across for you, Tom. Or if anybody would like to pose a question to Tom directly, please do raise your hand. You'll find the hand raising at the bottom bar on your screen, and we can come directly to you so you can have a chat with Tom directly. So please be formulating your questions as I ask Tom my question. So I get to go first. That's the joy of being a chair.
Shoot.
Tom, um, if you were speaking to somebody who was thinking about starting a project like this in their own health system,
Mhm.
what advice would you give them if you could look back at the very beginning? What do you wish you knew before you started?
That there is a standardized, there are tools available to help you on the journey. You do not need to start from scratch. Most of the time, it's already done somewhere else. But it's very important to get the problem you're tackling right, because it changes everything else, everything behind it. To give an example, we did it for post-operative care, but we also did it for heart failure. We
Mhm.
used the same methodology, but the focus is different because for heart failure, it's much more a chronic follow-up. So
Right.
it's not that acute.
Mhm.
You have different structures available in Belgium, at least. So define the problem very, 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 very good, and it will change the rest of the course. It will change the rest of the roles and the responsibilities you need to address.
There's an excellent piece of advice, thank you, and actually pretty excellent piece of advice for any piece of work, but specifically for this one. And as we're all in the world of improvement, understanding the problem before you start to solve it has got to be popped straight out of the improvement guide, hasn't it? So that's great.
Yeah. We,
Yeah.
we we noticed that everybody wants to use telemonitoring, and everybody wants to send the patient home as early as possible. But
Mm,
what are you going to do with the patient when something happens?
absolutely.
So it's very easy to use technology as kind of a shield, like, yeah, we're monitoring you and we're sending you home very early, but that's not the difficult part. When we went to the moon in the 60s, we already had remote patient monitoring. The astronauts were monitored on the moon. So that's not the difficult part. It's not the technology. It's what are you going to do when something happens? It's not okay just to see that there's something wrong with the patient.
Fascinating. You're so right. And yes, the monitoring seems like the bit that should be the
Yeah,
bit that we're all doing. But yes, what if something goes wrong? And then to have those procedures in place
yeah,
that your patient knows about, that's what helps them feel safe. Not the fact that somebody's watching them, the fact that they know what would happen if anything
yeah,
didn't go according to plan. That's really
yeah.
interesting.
Agreed.
Yeah.
And the human voice, talking to someone, not talking to something, is
Yes. Absolutely.
they really liked the 24/7 access to a healthcare provider who knew what was happening. So that was very, very valuable.
It is interesting the NHS near me work that was done up in Scotland, which was um, all around having telemedicine very early on across Scotland, and when they were co-designing that with local communities about what people wanted,
Mm.
people desperately wanted an actual person when they logged on. So there
Yeah,
are now remote receptionists who welcome people in because it's the actual human voice and a person on the screen
yeah,
that makes you feel comfortable with the rest of the process. Uh,
yeah. The rest of the process is evenly important, but you need
yeah.
that human touch. Just it's not always that clear what's wrong with a patient. Sometimes you can have physiological problems due to just being worried. And then you don't need to come back to the hospital. You just need to talk to somebody, um, somebody who has time to
Yeah.
listen to you. So that was very, very
Yeah.
valuable.
I guess that counts for caregivers as well. So people looking after the patients when they've gone to hospital as well. They need to have the confidence too, don't
Yeah,
they?
yeah, true.
Um, I'm going to ask again. If anybody has any questions, please do pop them in the chat for Tom. I have another question for you, Tom. You're allowed to say you don't want to answer these.
No. Go. Bring it on.
Um, I'd just love you to tell me a little bit more about the difficulties that you had with data for secondary use, because I think that comes up a lot in a lot of health systems, the data usage and the ability to use that. So can you
Yeah.
explain a little bit more about that and how you got around that?
Yeah, the biggest problem is that we do not own all the software. So we have different companies with different kinds of gathering the data. And our main problem was how to identify the patient, the same patient in all the different data structures.
Okay.
Because it's not so easy to, when you're sharing patient details, you need to be very aware who gets them. We have the GDPR, we have NIS2 now in Europe. Um, so, how are you absolutely sure that you're talking about the same patient in the hospital, outside of the hospital? And the denominator, how the patients, they're most of the time we're just using numbers to obscure the details. But in our case, every provider used a different number. So it was really bad. And it was not, I could ask them to change it, but then the cost would be too high just to continue with it. Right now, we're working on another system just to get them aligned, but it's not so easy.
That sounds like a big and tiresome job.
Yeah, and it's a technological question.
Yeah.
So they just need to align.
Just come on.
Yeah,
Come on, guys.
just align. But I can understand for a company that's not so easy
Yeah.
to align it and to change the way your data is structured. It's not so easy. I understand, but we need those data just to, especially if you're looking at health economics, we need to understand the complete process and every part of it to make a quality assessment of the health economics and the health technology. So
Interesting. That's a whole other webinar, isn't
yeah. Yeah, but not for me because
Oh no, we'll not drop you in that one then. Very good. Thank you. Um, it doesn't look like we have any questions from our audience. If anybody would like to pop their hand up to have a question for Tom, this
Mhm,
is the last call. No. Well, it's just been an absolute pleasure, Tom. Thank you so much for your time, for your expertise,
mhm,
and for your insights. I know that everybody who's been listening and everybody who will be listening on record will take a
mhm.
lot from your session today. So thank you. I very much hope we get to see you in Lisbon as well. For those of you,
We'll try.
that would be lovely. For those of you who weren't aware, the call for posters is open for Lisbon. So if you want to have a click on that QR code or hop on the website, the call for posters will be open until the 7th of October. So it's exciting time for all of this, all of us. If anybody would like to hear any more about the Lisbon Forum, or if you'd like some more information, you'd like to register on our mailing list, then please do scan that QR code that Molly's got up now to receive notifications for the Lisbon Forum. Um, for those of you who have joined us for the first time today, thank you very much for joining us. For those of you who are long-term friends and colleagues, it's been lovely to see you. And once again, a huge thank you to Tom for your time and for sharing all your work with us. And a thank you to Molly, who is secretly backstage, but she's been running all the tech for us here today. So thank you to Molly too. So with that, I'm going to close the webinar, and wish you all a very good rest of your day. Thank you so much for joining.